renal pharmacology, ACE inhibitors, as well as ARBs, okay? So last thing I'm going to be talking about for renal pharmacology, we're at the end, is our ACEs and ARBs. Okay, so ACE inhibitors, once again, what they're going to do, it's in the name, they're going to block the angiotensin-converting enzyme, okay? They're going to inhibit it, which is located where? Located within the lungs, okay? So remember, with the RAS system, what's going to happen is we have renin. Renin's going to be cleaving angiotensinogen to angiotensin 1. Angiotensin 1 is going to travel all the way to the lungs, where it gets converted by ACE to angiotensin 2, okay? Then angiotensin 2 acts on multiple receptors to cause, aldosterone, ADH, and overall increase in blood pressure, okay? So for ACE inhibitors, we're blocking that process of angiotensin 1 into angiotensin 2 at the lungs. And all ACE inhibitors end in PRIL, pril, okay? Captopril, enalapril, lisinopril, ramipril, okay? Now, once again, inhibits that ACE, leading to an overall decrease in AT2, as well as an overall decrease in GFR, okay? Now, angiotensin 2, as we said, what does it do? Angiotensin 2 constricts the efferent at the kidney, okay? And so when we have ACE inhibitors, they're going to lead to an overall decrease in angiotensin 2 down the road, right? And so that leads to a decrease in GFR because we start to dilate our efferent. And that decrease in GFR is really, really important because it points to one of our main clinical usages for ACE inhibitors, and that's going to be diabetic nephropathy. So patients that have chronic kidney disease and diabetic nephropathy, they can take ACE inhibitors in order to slow down the progression of the glomerular basement membrane thickening, and it's protective. It's nephroprotective. It's protective for the kidney. Very important. So if a patient has microalbuminuria, meaning that there's albumin in the urine, and they're diabetic, give them an ACE inhibitor because it not only stops that albumin from getting in there, it slows down the progression of the thickening of the glomerular basement membrane secondary to diabetes. Very, very great drug. Okay, so that's why it's indicated for diabetes. Okay, next, a clinical usage also obviously is going to be hypertension, heart failure, and these are decreasing mortality drugs. ACE inhibitors decrease mortality. Very important. Okay, now, what we need to know is that when we give ACE inhibitors, we obviously are inhibiting ACE, which leads to, inactivation of bradykinin. Okay, so we have the prevention of inactivation of bradykinin. So overall, you have an increase in bradykinin secondary to ACE inhibitors. Okay, so that means that bradykinin levels are going to be increased in patients that are on these types of drugs, and that leads to a dry cough and angioedema. Okay, so those are the two main adverse effects of taking ACE inhibitors. You have to know it, a dry cough as well as angioedema. And angioedema and dry cough is due to the fact that bradykinin is no longer being broken down. And so you have an overall increase in bradykinin. Okay, so we have also a contraindication in patients that have C1 esterase inhibitor deficiency, because they also have angioedema, which is just edema or puffiness, swelling around the face, the eyes, the nose, the mouth. Okay, so patients with C1 esterase inhibitor deficiency, it's contraindicated to take ACE inhibitors because of the rise in bradykinin, which leads to angioedema and a cough. Okay. Secondly, another adverse effect is that we're going to see a rise in creatinine, specifically when patients have renal artery stenosis, because we already discussed it leads to a decrease in GFR, which can cause a bump up in creatinine. Lastly, an adverse effect of angiotensin-converting enzyme inhibitors or ACE inhibitors is hyperkalemia and hypotension. Okay, and those should be relatively straightforward. All right. Lastly is angiotensin 2 receptor blockers. Okay, angiotensin 2 receptor blockers, instead of blocking the ACE enzyme, angiotensin converting enzyme, it's going to block the receptors in which angiotensin 2 works on. Okay, so it essentially has the same effects as ACE inhibitors, but it's just one step later. Okay, so you actually do have the formation of angiotensin 2. And the question that they love to ask is the levels of things. So what's the levels of angiotensin 2 when a patient is taking ACE inhibitors? It's decreased. What's the levels of angiotensin 2 when patients are taking ARBs? It's actually increased. All right, does that make sense? Because in ARBs, we're not blocking the conversion of angiotensin 1 to angiotensin 2 as we would in ACE inhibitors. We're only blocking the location in which angiotensin 2 works at. Okay, so we're not blocking the formation of angiotensin 2, we're just blocking the area in which it works. And that's a very key concept. The only other difference as well between ACEs and ARBs is the fact that ARBs does not cause an increase in bradykinin. So you don't see the adverse effects of dry cough and angioedema with ARBs. Lastly, ARBs end in sartan, S-A-R-T-A-N. So you have losartan, okay, and valsartan. Those are the two ones that are very common. And some adverse effects are, once again, hyperkalemia, a decrease in GFR, hypotension, and both ACE inhibitors and ARBs are teratogens, so you can't use it during pregnancy. All right, so that's pretty much it. We've covered pretty much all the pharmacology as well as pathology and everything else for the renal section. If you have any questions, please feel free to reach out to me. And that's all.